that help. We forgot to record. That help to improve the health of our representative populations and the way they engage with health systems. So for us, we are Good Things Foundation. We are a digital inclusion charity. And our mission is to fix the digital divide, and that's about getting everybody access to the online world who wants and needs it. And we do this through three really core parts of our offer. So firstly, we offer support. We have a national digital inclusion network, which is a network of hubs across the UK who offer frontline support to people who want to get online, be digitally included, access online services. And we also have a learning platform called Learn My Way, which sits alongside that they use to help people grow and develop their skills. We also offer the National Data Bank and the National Device Bank. This is a way where people can get access to free data, mobile data packages, or free devices to help them resolve any access issues they've got about being online. Loads more that you can find out about that, but I don't want to spend too much time on it. There are links at the end of the presentation, but if you are interested in finding out more about our offer as an organisation, please don't hesitate to get in touch. We'd love to hear from you. So like I said, this seminar is the first of three, and the aim of these seminars is to draw together all the learnings that ourselves and other partner organisations within the Alliance have gathered over the last 2.5 years since this round of the Alliance has been running. Many of us have been working on projects that have had a digital inclusion element, or where we've been exploring the issues around digital exclusion for the populations we represent. We've all produced some fantastic outputs and reports, which are all available for you to read, but this was an attempt to draw together some of the themes that we were all seeing across all of our work. So this first session is about exploring how digital inequalities overlap with health inequalities and surfacing some of those things. The second seminar is about exploring the barriers that excludes people from digital health services and surfacing those a bit more. And then the third seminar focuses much more on how you design your solutions to help people be more digitally included. We're very excited to say that all three sessions are fully booked. So if you aren't booked on seminar 2 or seminar 3, but would really like to see the content, we're recording them all and we will share links to them post event. So don't worry, you're not going to miss out. It's just you perhaps might miss the opportunity to ask live questions, but all the links and contact details for people who are presenting will be in those presentations. So you're not going to miss too much by not being here. Today's seminar is focused on building your understanding of health inequalities and protected characteristics and how that overlaps with the risks of digital exclusion. We will be exploring the framework for NHS action on digital inclusion, and we're delighted today to be joined by colleagues from NHS England, the Learning Disability Alliance, Friends, Families and Travellers and the British Red Cross, and you will hear from all of them, as well as a representative from our organisation, Good Things Foundation. So I'll just talk you through the agenda next. So we're going to start up to hearing from Bola from NHS England. She will talk you through the framework for action on digital inclusion. Then our own Dr. Emma Stone will come in and share some of the findings from one of the projects that we have been doing as part of our work within the Alliance around mitigating risks of digital inclusion in healthcare. Then we will hear from Madeline and Lynn at the NDTI, followed by Michelle and Mihai from Friends, Family and Travellers, and then finally Lois from British Red Cross will join some of their projects that they've been doing. The last three sessions are designed as case studies, so they will give you some examples of their audiences and how they are impacted by digital exclusion. And then at the end, there is space for Q&A. And just a reminder, leave your questions in the chat as the session runs through, and the amazing Jo and Meg will sort through them, gather them up and pose some of those questions to the speakers at the end. But again, contact details will be there if you want to follow up afterwards. So I can't see, but I'm hoping that Bola is here already.
He is, yes. Katie, just
Oh yes.
you won't mind moving on to the
Yeah.
perfect. Next slide, thank you. Just before we move on to Vola, we're really interested to understand a bit about how these seminars land with the people, with you and the other people who'll be attending the seminars this week. So it'd be really helpful for us to gather really quickly a bit of information about who you are, who's in this virtual room today, and how much knowledge and confidence you feel you currently have about digital inclusion and access to healthcare. So we've got a really short poll with 3 questions that we'll ask you to do now. And then towards the end of the seminar, we'll repeat a couple of those questions just to see if there's any change in your knowledge and confidence. So I will launch the poll, and what you might need to do is scroll down a little bit just to see the 3rd question. They're all on one page, but you might need to scroll down to access the questions 2 and question 3. So hopefully you can see that on your slide now. We'll give you a few seconds to fill that in, but please do scroll down for the other questions. I can see the numbers going up nice and swiftly. Thank you very much. Give it a few more seconds. Final 10 seconds to get those answers in if you've not done so already. Okay. That's looking great. All right, I think what I'll do, I'll end that poll there. Thank you very much for that information. And as I said, we'll do a quick repeat poll at the end of the session. Thank you. Back to you, Katie. Katie, you're on mute.
Oh, sorry, I'm getting used to this. So yeah, without further ado, I'll hand over to Bella and I'll ask her to introduce herself and share her few slides. Bella, just give me the nudge when you need me to move on to the next slides, please. Are you there?
Bella, we can't hear you, unfortunately.
Can you hear me now?
We can.
Okay.
Yes, brilliant.
So I'll start again. Really delighted to be here to join you for this really exciting programme with 3 seminars. I hope you all enjoy them and that there's lots useful, I know there will be, for you to take away from the conversations. So I just wanted to do a bit of scene setting. I'm sure lots of you will have heard about our new framework for NHS Action on Digital Inclusion. So I'm Bola Akinwale. I'm the Deputy Director for Policy in the National Healthcare Inequalities Improvement Programme. And I have a broad remit around supporting the entire NHS to tackle inequalities, which means partnerships with many organisations and colleagues, including colleagues working across the VCSE sector. So we're really delighted to kind of connect with everyone today. Next slide, please. So, look, digital is so important to all of our lives. In every aspect of our lives, we are using digital, and the healthcare sector is no different. We've seen a really big rise in the adoption of digital technologies across the NHS. And so you can see some of our important factoids there. So we've got around 10 million more people in the UK who are using NHS websites or digital applications in 2021 compared with the pre-pandemic year. Equally, we've seen a rise in NHS app registrations up from 2 million people in 2021 to 30 million people 2023. So a really massive rise in the ways in which we're using digital technologies in the NHS. And of course, those modes, those channels are not the only areas where we're using digital. There are many other ways, digital therapeutics and so on, which I'm sure lots of you will have encountered. But our challenge is that we know that some groups and some households are still struggling with getting online and will struggle with the technologies that we want to roll out. So You can see here that, for example, about 1 million people are reported to have cancelled their broadband package in the last year due to rising costs. About 10 or 11 million people, I think now is the estimate, are estimated to lack the foundation level digital skills. And many report that the NHS is one of the most difficult organisations to interact with when they're offline. And I'm sure all of us will have encountered in different ways some of these issues. So there's a really important thing for us to think about. What is it that we do to enable those people who might face challenges in using digital technologies or interacting in digital ways to get access to healthcare and have good experiences of it. Next slide, please. So it's really important that we think about that, both because it's important, but also for NHS England and ICBs, we have particular duties on health inequalities, which are relevant for thinking through the issues around access, experience and outcomes as they relate to digital, or the issues of digital inclusion. So you can see there what's quoted from the law, from the Health and Care Act 2022. ICBs, this is the form that relates to ICBs, but it's the similar wording for NHS England. We have to have regard to reducing inequalities between people with respect to their ability to access services and in relation to the outcomes achieved from the provision of healthcare services. And the law is really clear that that includes patient experiences. So there's something really important in us to think about when we're designing services, and we need a digital element to be clear about actually, are there any issues of access that are presented by these new things, but equally, are we giving people good experiences and supporting better outcomes? And so the policy context really provides a driver for making sure that we're considering the issues of digital inclusion throughout all of our work. Next slide, please. So we know that some groups are at a greater risk of digital exclusion, and these tend to be groups who might otherwise face a higher risk of health inequalities or have poorer access to health services, worse experiences, or indeed poorer health status. So this includes older people who are aged 75 years and older, particularly, people in more socioeconomically disadvantaged groups where we know there's a social gradient in health and in other social outcomes. Socially excluded groups, so those groups who are particularly facing issues to do with discrimination in access to services, such as people experiencing homelessness, those in contact with the criminal justice system, asylum seekers, so those are known as inclusion health groups. We know that disabled people and people with life-impacting conditions might face particular challenges in using technologies, and also those people who are living in areas where there might be lower broadband or mobile data coverage, such as rural or coastal areas. So there's a whole range of groups where we need to consider specific needs and specific access issues where people might be digital excluded. Next slide, please. So across the NHS, we've been thinking about, well, what is it that we need to focus on in relation to health inequalities? And we have 5 priorities for action, which you can see on this slide. And they're set out in operational planning guidance to support all of the systems across the NHS and providers to make sure that they're focusing on a common set of issues to really make progress on inequalities. And of course, we particularly highlighted the importance of action to mitigate against the risk of digital exclusion. So that's why we have come up with our framework. We really wanted to provide more meat on the bones of what that means and what it looks like. And I'm going to talk a little bit about what the framework covers now. Next slide, please. So we wanted to do a digital inclusion framework because we recognise that there is a lot of good work going on across the system and across sectors, not only in the NHS. You know, the NHS hasn't necessarily stolen a march on doing the good work on digital inclusion. It's happening in many sectors. Our colleagues in local government, you all in the VCSE sector, are all doing fantastic work in this space. But we really wanted to make sure that there was something visible to help NHS staff to really think about these issues and ensure that when we're designing digital approaches or intervention, or we're trying to roll out things that have a digital element, that we are doing it in ways which enable access and improve experiences rather than disadvantaging people. And so we do that recognising that, you know, this isn't the NHS operating in isolation. This is a whole of society issue with all of these partners requiring collaboration at all levels of the system and across sectors. We do it recognising that as much as we talk about the importance of, sorry, I've lost my screen.
Hang on, bear with me. Let me drag that.
I'll carry on speaking, but we do.
Hang on. There we go. Let's. There we go.
Yeah.
There we go.
Yes, it's okay. We do that, recognising that as much as we see the opportunities around digital interventions, it's really important that we maintain non-digital routes to access services and to receive care to complement those digital offerings, because it may not be people's preference to work in digital ways, or indeed, you know, they may particularly struggle. And that there is a group of people who are experts in user-centered or human-centered design who can help us to do the really good product development and ensure that it's embedded into general inclusive design of services. So that's really important that we draw on that expertise. Next slide, please. So our framework has got 5 domains for action. They include making sure that we work on opening up access to devices and data, that we think about the accessibility of our technologies and the ease of using them and develop great content, that we look at the skills and capabilities of both our staff and patients and find ways to build them up, but that we also look at some of the psychological factors, the beliefs, the trust, the motivation that people have to use different digital approaches. And of course, cutting across all of these things, we recognise that it's very important that we have the right leadership in place and the right partnerships to drive systematic action. So I've said we recognise all of the good work going on across sectors, and we really just want to join up and make sure that that is happening. So you can see some examples on the slide of some of the specific tips that we've put in the framework on how these things come to life. So the framework has case studies in it. I'd recommend that you go and have a look at it. We can post a link in the chat, but you're going to have really important and interesting case studies to talk about today and hear from our colleagues from the different organisations. So I won't go into any detail about case studies, apart from to say I think there are a range of really excellent examples of how you can bring some of these points to life, and I'm really looking forward to hearing more from what colleagues have got to say about that. Next slide, please. So that's it from me. Thank you. I hope you enjoy the seminar. I'm really interested in hearing the findings and really welcome some conversation.
Brilliant. Thank you so much, Bella. I'm really pleased that you've been here. Well, Bella has been guiding us through the setup of this seminar series, which has been fantastic, but great to have you setting the scene at the beginning of the session. And apologies for jumping to another document mid-session. Fantastic. So on to our next speaker, keeping us as close to time as we possibly can, which I'm delighted to say is our very own Dr. Emma Stone, who is our Director of Evidence and Engagement. So I know Emma is a little nervous about her internet connection, so she's going to perhaps keep her camera off, but I will hand over to you, Emma, and I'll move through your slides when you tell me.
Brilliant. Thanks so much, Katie. Yes, I'm here, so saying hello to everyone, but I am going to keep my camera off. Yeah, so next slide, Katie. So, following on from Bola and her scene setting around the framework for action, I just wanted to take a bit of a step back and think about the big picture here around why the digital divide matters so much in the United Kingdom. So Digital Nation 2023, this is the latest in a series of visuals that we've been producing for several years now to tell the changing story of what is happening in terms of digital inclusion and exclusion using data from sources like Ofcom, the Consumer Digital Index and Essential Digital Skills Reports. And I remember when I joined Good Things Foundation 5 years ago, that that analogy of a divide sounded right, sounded fine, but I kept on, and we still keep on wanting to draw attention to the fact that this is not a linear process. You can slide back across the divide, as it were, when you are no longer, for example, able to access the internet because you can't afford it, or you face more challenges in terms of skills and keeping up and keeping on learning. But actually, there's a real spectrum in terms of digital exclusion, and it can be all different sorts of reasons that mean you face digital barriers in benefiting from the online world. But the thing that taking a step back and looking at it like this also reminds is the benefits around being digitally included, and the benefits across different areas of people's lives as well. And so that does mean that in 2023, despite having some some world-leading digital infrastructure and a lot of activity around digital inclusion, the reality is that the pace of digital inclusion, of people living in communities in this country, isn't keeping pace with digital transformation of online services and of our lives. And so that's why the divide is so stark and is such a cause for concern. Next slide, please, Katie. So the reason for the big red curve through the middle of digital nation is something called the Matthew effect, which is effectively what happens when those who have wealth and have assets are able to benefit through accruing more, and those who don't end up being left further behind and their exclusion becomes deeper. And digital is one of those assets and enablers that where absolutely we can see this happening. So if I have the skills and confidence, if I have the support from my family, friends, from my workplace, if I don't have to worry about paying for, an up-to-date device that can download the, latest apps and enough data connectivity, then those benefits are going to continue to accrue to me in my life. And the opposite is true for those who face significant digital barriers. Next slide, please, Katie. And so we're again going back to that point around the mismatch between the pace of digital inclusion of people and the pace of digital transformation of services, then clearly the shift towards services moving online excludes many. And this is why we were so delighted that the NHS Framework for Action on Digital Inclusion is underlining that point about it is essential that non-digital channels remain available to people. But nonetheless, there is significant use of digital channels going on within the NHS and also across all the areas of people's lives. And this really matters because of that wider piece around health inequalities. Everyone in this room will know that our opportunities and chances of a healthy life are mostly determined by things outside of our use and access to actual healthcare services. So it is about education and employment and participation and well-being, and it is about income. And so in all of those areas of our lives, as services move online, then actually that will have direct impacts on people's lives and people's health. Next slide, please. And so as those services move online and become less accessible for people, we know that people are then struggling to interact with them. The data on the left-hand side is from the Consumer Digital Index, and they, in 2022, asked the question of those who don't have access to the internet, how they are finding accessing things like the NHS, and 1 in 3 said they struggle to interact with the NHS. Last year, Good Things Foundation, we did our own poll, and bearing in mind that this was a poll nationally representative, but of people who are online. So even among those who are online, 1/3 of people were worrying that they weren't able to access services in a way that a provider wanted them to. And in fact, 1/5 had stopped using products or services because they were only available online. And this is a really important message because it is about that that spectrum, that fact that just because you have some access doesn't mean you are fully confident, or that your preference and choice is to be able to use all online products and all online services. Next slide, please, Katie. So picking up on some of the things that Bola was talking about in terms of the different groups that are more likely to be affected by digital barriers. And those barriers might be around, as I said, not being able to afford the internet in terms of devices, in terms of sufficient data connectivity, but also then lacking the skills and the confidence. And what we see repeatedly from all the data, whether that's our data, whether it's Ofcom's data, Consumer Digital Index from Lloyds Bank, NHS data, we are seeing that being offline and also using the internet in a limited way is really linked to poverty across all ages. It is socioeconomic disadvantage and the related disadvantages of that are really impacting people's ability to engage fully online. But of course, this is a big area then where we see intersectionality with some protected characteristics and also with other circumstances. And Bola's already highlighted how this intersects with the experience of people who are from inclusion health groups, where already worse health outcomes are more likely. And there is obviously also a geographic element to this as well. It's more than thinking about the connectivity infrastructure. And of course, that can happen to you in urban areas as well as remote and rural areas. So there are urban not spots. There are some forms of accommodation in urban areas where it's harder to get sufficient connectivity. But it's also about area deprivation. And it's also really importantly about the availability of local support to help you, whether you're accessing services online or offline. So intersectionality between digital use and many, many other characteristics of individuals, of communities, and of wider locations. Next slide, please, Katie. So a bit of a spotlight on protected characteristics now. So age. It won't be a surprise to many people here that it's older people, especially those who are 75 plus years old, who are much more likely to be non-users or lapsed users. So in other words, they've stopped using the internet or using it so much, or they're only using the internet in a very limited way. But again, what you see here is the intersection between older age, albeit the most significant predictor of non-use, but also then other aspects. So you are even more likely to be a non-user, lapsed user, or limited user if you are older and on a low income and living alone. And a big reason why a large number of older people may stop using the internet each year, that's often then related to the onset of health conditions and impairments. And again, this is why in the NHS Framework for Action that Bola outlined earlier, it was so important and great to see a domain there that's calling out on accessibility around design, around assistive software and technology, both for older people who've developed impairment-related who may struggle to access the internet related to impairment or health conditions, but also for younger disabled adults as well. And whilst we're focusing on age, a reminder that it isn't the case that because you grew up in a digital age, that therefore you don't face barriers. So this again is where poverty in particular, but also for some children, young people, issues around maybe impairments and around disability may also impact on what they need and their ability to be able to benefit from the internet. And there are some good news stories here as well. One of the things we and others fight really hard against is the assumption, any ageist assumptions that because you're older, therefore you do not want or you're less likely to be able to be skilled and keep up and benefit from digital. And actually, we know that there is strong use of the internet also among older people and of use of services, including the NHS app. But the barriers, this is a group for whom actually lack of interest. Bola was talking about motivation, fears, distrust. Those are all key factors we know from people who feel they do not do not feel confident to use digital services. And there's also something here about not wanting to have to rely on other people, not wanting to have to ask your family for support, and a preference for being able to get that support in person or by phone, and not end up kind of locked into only being able to access digital support. Next slide, please, Katie. So in terms of disability, I'll say a few things here, but I'm really delighted that also colleagues from NDTI are going to be sharing their findings shortly around digital exclusion and people with learning disabilities. But again, here is a protected characteristic. There are quite strong intersections with digital exclusion and with the likelihood of facing barriers. And some of those are pretty inextricable from then links with other things like older age, but also like income and poverty and educational attainment and broader life opportunities. So there's a big intersectionality element here. And also a reminder that there can be harms. You know, internet use can worsen mental health conditions in terms of, you know, online harms and the dangers inherent in the internet. And that's one of the other reasons why we do keep reiterating that when we talk about digital inclusion, you also have to think about the local infrastructure of support that is available to people, because those are the things that can help people to benefit, to stay safe, to be resilient in a digital world and when using the internet. And there are lots of...
to interrupt, just to give you a 1-minute warning, just to keep the time. Thank you.
Okay, thanks. Thank you. So there are lots of benefits and lots of barriers, and I'm sure NDTI will be talking from their case study about those. So I'll move on to the next slide, but just really want to call out one of those benefits being around independence, choice and control in people's lives as a whole, as well as in relation to health. We're going to be sharing these slides later. And so we're also going to be hearing later from Friends, Families, Travellers, and also British Red Cross. But one of the really frustrating areas when we think about protected characteristics and the intersection with race, with ethnicity, is there are still major gaps in data around this. And a lot of the time that comes from low sample sizes within national data sets that then means we can't really drill down. And the data can be complicated too because of the younger demographic profile of some minority ethnic communities. But I think what's really important here is, as well as those, some of the issues around, for example, low trust and mistrust in digital public services are likely to also be about low trust and mistrust in public services more broadly. And so digital is a layer on that. But also what's really pulled out, and I think you'll hear a lot, certainly in the findings from British Red Cross in terms of refugees, people seeking asylum, is that actually there are groups that do want to do things like being able to access the NHS app, and actually they face barriers in doing that because of things around, say, verifying their identity, but also English language barriers and challenges around navigating the system, whether it's online or offline. Next slide, please, Jo. So there is so much we don't know, and also so much we can do. So here on this slide, you'll see a link to a report, a review of evidence and a review of key areas of barriers and potential solutions to those barriers, which we pulled together as part of our work for the Health and Wellbeing Alliance and with BOLA as our policy lead. So that guide is available on our website, and we're going to be updating that with some new resources that have been published over the last year from Alliance members and others. So, and I do really want to underline that even though we do need more knowledge, insight and data, at the same time, we also know enough to take action on what we know now about the reality of digital exclusion, around the importance of accessible, inclusive design, the need to build public trust in online services, and to respect people's preferences, which means keeping non-digital channels open alongside supporting digital inclusion. And so I think for me, that is a key takeaway. And the final slide is just to say, alongside that challenge and that call to action. So next slide, that Good Things Foundation and our resources are previously, great. So Good Things Foundation, we are absolutely here to support you if you are wanting to address this in your community with the people who use your services. We have the offers that Katie outlined earlier, and we really want to be able to support you to do what you can in addressing digital inclusion. Thank you.
Brilliant, Emma. Thank you so much. And we're almost on time, so that's even better. So yeah, lots more to find out, but that was a whistle-stop tour, and we'll make the slides available. And please feel free to get in touch if you want to explore more. So next speakers, I am also very excited to kind of link from some of the themes that Emma was surfacing there into colleagues from NDTI who are part of the Valuing People Alliance, and to introduce Madeline and Lynn. So are you there, both of you? And do you want to say hello and introduce yourselves?
Hi there.
Hi there. And I'm Lynn. And we're from NDTI and we're not in the same place. So do bear with us if we randomly talk over each other.
I was going to give you a bit of background on health inequalities, and then Lynn will tell you about a project that we did a couple of years ago now, one of the first of the sort of mini projects from the Valuing People Alliance in terms of our annual kind of what we're looking into. Can you move on to the next slide, please? Yeah, so NDTI is a development organisation. We work across the UK, and we also work across lots of different groups of people. Tends to be those who are excluded, sort of have societal exclusion, but are usually in contact with health and social care. So people with mental health issues, people with a learning disability, older people, and so on, children and young people with disabilities. When we are part of the Valuing People Alliance, we are specifically thinking about people with a learning disability. And we were a member, we've been a member for a number of years, the Health and Wellbeing Alliance, within a sort of smaller version of the Valuing People Alliance. But during COVID, when social contact, health contact, etc., moved online during lockdowns, we were working with a group of people with lived experience to support them to feed into what was at the time Public Health England, in fact, but also supporting some other people to be part of the Valuing People Alliance and feed into the work that we did here. And we had some very interesting and fun interactions trying to get people online, trying to get people to learn Zoom and kind of on the, kind of literally practically helping people be able to connect. And actually, when we could, the benefits were huge. So there were some real positives. People could get together socially, people didn't have to travel as far, and some of the people that we worked with, travel was a really big issue. So we saw some real benefits, but we're also really aware that it doesn't always work for people, and a lot of things. So annual health checks, for instance, GPs were starting to offer online annual health checks to people with a learning disability. They're entitled to one every year. And those were going online. So what did that mean? Were people able to access them? So we realized there was probably a link, and possibly digital exclusion could lead to additional health inequalities. The project we did that we'll tell you about was more about exploring with individuals. What does it take? What do you need to be digitally included so that these things don't get in the way and these barriers don't arrive? I'll just do a couple of slides on health inequalities. The data on this slide is taken from the most recent, what is known as the LEADER report, Learning from Deaths report. So people with a learning disability have a life expectancy of less than 63 years. That's the median. That is 20 years less than the rest of us. And this is just a tiny bits of a picture, 42 deaths of those were deemed avoidable in 2022, reported last year. So we've known for a number of years. So back in 2007, MenCat published a report called Death by Indifference, which explored in detail the deaths of six people with a learning disability. And on from that, there was a confidential inquiry into why people were dying younger, led by the Nora Fry Centre. And then after that, the LEADER programme, Learning from Deaths programme, was introduced by NHS England. So if people die, the deaths are generally explored and tried to be understood so that we can look at what is leading to those. So that's the picture in terms of kind of that life expectancy and what happens. And more recently this year also, autistic people have been added into the leader report, so people have started looking into that as well. If you go to the next page though, there's the kind of a lot of health inequalities, a lot of the reason for it have social determinants of health. So it's not just that people have comorbidities or physical issues that sit alongside their learning disability. There are social determinants. And actually Michael Marmot did a specific report. I was trying to remember when that was, I think 2019, into the specific social determinants of health inequality for people with a learning disability. So I've pulled some of those out here. And I'm just trying to look at, what does this mean? How does this cross over with digital exclusion? So some of the social determinants, fewer people with a learning disability are in jobs, less than 6% this year. It's gone down. That is not looking great. There's much higher levels of that kind of intersectionality of poverty, dependence on benefits. People are often in poorer housing. People are often in group settings, forced into group settings when they'd rather have their own space. People's rights are not always upheld. People tend to have lower social capital, fewer social connections, particularly fewer people that they know based on work or interests, and more people in their lives because they are paid to be there or they are also disabled. So if you think about it, there's the crossovers between having less money, having fewer people around who might help you or say get online, lacking the opportunities that work gives us to learn to use computers, phones, etc. All of those things can lead to digital and exacerbate digital exclusion. The access and support, when we look at the crossover directly with health issues, as more health things move online, as our GPs need our bookings to be online, as our kind of consultations are online, etc. What we know is, and we know this from the leader reports, that that health services are not brilliant at understanding or adapting how they communicate or how they understand someone with a learning disability. And there is very common experience of something called diagnostic overshadowing, where the way that the person is communicating to say, I'm in pain, or this is wrong, or might be indicating that something's going wrong, is attributed to their learning disability and not seen or explored as a health issue, and people die for those reasons. But that's that thing about people being able to communicate and people being understood is really, really key. And so often online communication apps and so on might not be tailored or simplified in a way that people can understand or use it, or they might not be supported to use it. And then there are issues around attitude and stigma. There's a couple of examples there, but it's the assumptions about people's ability or lack of ability that means they may not be supported to even get a computer, use a computer, get a phone, and they might well be able to do it with that support. So that can actually mean that people don't get the support they need or they should be able to. Now, the work we did wasn't research. So we didn't ask how many people is this happening to, where is it happening, etc. This is our kind of understanding from working with people and exploring the issues. So I'm going to hand over to Lynn to tell you about the project that we did do and what people said should happen.
Thanks, Madeline. I'm just going to whiz through these kind of relatively quickly, but just picking up on a couple of the things that kind of Madeline said. One of the main enablers and also main barriers to people getting online was support, and lack of support, and good support. But kind of something interesting was very often the people who were supporting the people with a learning disability to get online were also digitally excluded themselves. But they may have been older people, they maybe didn't earn that much money, they weren't kind of practiced at kind of using technology, and so they weren't actually able to support people to learn, because of their own exclusion. So anyway, kind of back to this project. It was a really small project that we did as part of the work with the Health and Wellbeing Alliance, as already kind of been described. And it was actually right at the end of 2022 going into 2023. And as you all know, and as Madeline said, during the coronavirus pandemic, lots of stuff went online. And we were worried that kind of digital exclusion may have been affecting adults in kind of several ways. Like, for example, they might not have been able to readily access health advice, to get to medical appointments, or to be able to access kind of support services for the housing or the social care. And so we thought, let's do this project, because we wanted to help health and social care services and partners to make sure that people with learning disabilities and autistic people could be digitally included. And so the goal of the work we did was to co-produce the a top tips document. And one of, you can go to the next slide. One of the first things that we found out was that there was already a load of really interesting work out there. And there was a lot of really interesting work going on in academia. And kind of looking at the people who joined at the start and where they said they were from, I didn't actually notice anyone from academia had joined in, which is a shame, because there's some people doing amazing work out there. Loads of work was actually done in the OU, and not all of it was published. Like kind of Sue Caton did a really interesting piece of work on online social connections and internet use among people with a learning disability, kind of particularly kind of during COVID-19. Kind of Jane Searle did a whole load of stuff around supporting people with learning disabilities to use tech. And kind of Jane Searle and the Learning Disability Research Unit at the OU are kind of still doing loads of stuff. Also, kind of Chris Hatton from kind of Manchester did a load of work researching key issues for people with learning disabilities. And one of the things they looked at specifically was experience of using digital platforms. And as we've already kind of been discussing, as with lots of other groups, digital exclusion is a really key issue among people with learning disabilities. For all of the reasons that have just been described, they mightn't have access to digital platforms, either due to not having the appropriate equipment, like not having a modern enough smartphone, or because they haven't got the skills or the confidence. And then people living with older family carers who don't have access to the technology, like they've also really struggled. But we also found out that kind of digital platforms are kind of potentially more inclusive for people. Like, as Madeline described them, with the work that we were doing with the old advisory group to what was Public Health England, kind of one of the things we found out when we were talking to them, when we maintained contact through COVID, was how for some of them, particularly those that had adult children that were autistic, they actually preferred kind of having appointments online. It wasn't as stressful. And so kind of things moving over to digital were actually really positive for some of them. So a whole bunch of people helped us with this, and some of them are on here. And some of the most important ones for me were the self-advocacy groups. So My Life, My Choice, Inclusion North, Inclusion East, and kind of Pathways from Manchester. And they were some of the most important groups, because what they did kind of during COVID out of necessity was just really support the people that were part of their networks. They went round, they begged, they borrowed, they stealed, they got phones for people, they got tech for people, and they supported people to know how to use it. And because of that, loads of people started to like experience the kind of positive kind of benefits of going online. And I was really surprised by, I don't think I met anybody with a learning disability when I was doing this who wasn't prepared to have a go, or who wasn't capable of learning how to do some stuff on it. And so my prejudice had been around capability, but kind of the barriers were kind of very rarely to do with that. It was to do with not having the equipment, not having someone to support them to actually get on and maybe actually press the buttons, and not being able to afford to use the tech. Can we go to the next one, please? Sorry,
Lynn, sorry to interrupt. Just 1 minute left to finish up.
Oh my God!
I know, but we've got to keep
Let's just go straight to the top tips, because they're the most important ones. So we did a whole bunch of scoping. We talked to loads of people in academia. We found that there's loads of good stuff out there. Then we pulled all that together. We had some focus groups, and we shared what we found with people, and we asked them to prioritize it and to tell us what helped them and what got in the way. And they produced this document. You can see kind of half of it there. And they haven't contradicted anything that anyone said so far. One of the most important things was actually starting with people, was actually involving people, asking them what their preference was, finding out where they lived, kind of finding out how they like to be supported, finding out, just what their circumstances were. And then if you were designing systems, then actually use the people to actually design the systems, can design with them. Lots of people talked about how social prescribers could help them get online, which I thought was like really interesting. And number 4, the big one, don't do what I did and assume that people didn't want to do things. But also I was really pleased to see that like the NHS aren't going to make everything digital, because that was just a really important point, that sometimes someone just wanted to talk to somebody. And wherever you design, make it really easy, spend time helping people to build confidence, to be able to get online. A massive one actually was around websites and trying to find information. There's very few websites that have an easy read version. And so lots of people with a learning disability, even if they can get online, when they get there, they can't actually understand the information that's there. And that's something that would be relatively simple to do, just in partnership with a local self-advocacy organisation, just to make a page that was in easy read. It really helps people if you provide paper instructions for how they actually get online, and just make time to talk to people. That was it. It was that simple.
Brilliant. Thank you, guys. Thanks so much. And just to do a trailer in terms of the 3rd seminar, what we're going to do is take a number of different top tips and kind of summaries of how to do this well and pull them together. So we're definitely pulling these in, and you'll see more of them in seminar 3. So yeah, thank you so much for your time, and stay online because we'll do questions at the end. I'm delighted now to hand over and bring in Michelle and Mihai from Friends, Family and Traveller and the Roma Support Group, who are going to talk you through their case study. Are you there?
We're here. That's nice to see you.
Nice to see you. Over to you.
What I'm going to do is I'm going to go over the first part quite quickly and then pass on to Mihai, if that's okay. So if you can move the slides on, because I know we've only got 10 minutes, which is not long for us. So a quick introduction to Gypsy, Roma and Traveller communities. The term Gypsy, Roma and Traveller actually encompasses a lot of various communities, and that can include Romany Gypsies, Scottish, Welsh Gypsies, Romany people, more widely known as Gypsies, Irish travellers, new travellers, boaters, showmen and Roma. That GRT grouping is often referred to by governmental departments, and community members don't particularly like it at all. That little slide there, when you do get the slides, you can go into it a lot more depth and look at a wonderful video which is produced by the Travellers Times, and it will give you a short history of Britain's nomadic communities. Do you want to move on to the next slide? So briefly, Friends, Families and Travellers has been around for about 30 years now. We're a leading national charity, and we seek to end racism and discrimination against Gypsies, Traveller and Roma, and to protect the rights to pursue a nomadic way of life. We work with around 4,000 individuals a year, and with lots and lots of issues ranging from health to homelessness, education, financial inclusion, etc. Again, you can look at these slides in your leisure. I'll briefly introduce Roma Support Group, and then Mihai can talk later on a little bit more about Roma's footprint. RSG is a Roma-led charity based in East London, working to improve the quality of life for Roma refugees and migrants by helping them to overcome prejudice, isolation and vulnerability. And RSG support around 2,000 Roma people with access to welfare, health services, including mental health, education, financial inclusion, campaigning, policy houses and cultural activities. So together with the Health and Wellbeing Alliance, we form the Health and Wellbeing Alliance's Gypsy, Roma and Traveller Consortium. So if you want to move on to the next page. So we're going to talk a little bit about health inequalities experienced by Gypsy, Roma and Traveller communities. So members of the Gypsy, Roma and Traveller communities have the worst general health outcomes of any ethnic group in the UK. Gypsy or Irish travellers in the 2021 census respondents were more than twice as likely to report bad or very bad health compared with the general population. The statistics in the 2021 census are pretty shocking. We're still working out what we're putting into our briefs, but we know that Gypsies and travellers have life expectancies of between 10 and 25 years shorter than the general population and live around 6 less years in good health before life expectancy is considered. And this is an important one. Gypsies and travellers are not in the data doc dictionary, so we have to get our data from other methods. So the census is one thing, but bear in mind that it was only in 2011 that Gypsies and travellers were actually included in the census, and it was only in the 2021 census that that's been disaggregated between Gypsy, traveller and Roma. So, you know, some of that information is not there, so we have to take into account what we believe and some of the formulas that have been given to us by the Equalities and Human Rights Commission. We do know that people who are Gypsy and traveller people are known to be presenting, if you're in your late 50s, early 60s, as if you were someone in your 80s, and that's according to a Manchester study, and it's quite shocking, really. I have to say that things going on, I'm very passionate about reducing health inequalities because my own husband died at 48. He was an Irish traveller man, and that is normal within the community. That's normal. People say from the wider community, oh, that's no age, he was a really young man. In the traveller community, it's just like, oh, poor fella, end of. So it's really important to take that sort of on board. Roma individuals have multiple overlapping risk factors for poor health and life expectancy, up to 10 years less than non-Roma communities in the UK. And amongst Gypsy, Roma and traveller communities, mental health is rarely discussed openly. And even the term mental health is shied away from, with people preferring to refer it to as bad nerves. And otherwise people are very, very cautious about using the word mental because of the connotations that it's had historically, and also the fear of it's a very permanent word as compared to something that's temporary. But please look at the slides and go into that a little bit more detail. So amongst the Gypsy and traveller communities, we are looking at travellers themselves, Gypsies and travellers. The health inequalities are 6 times more likely to die by suicide than the general population. These are all cited. 20 times more likely to experience the death of a child as a mother. Gypsies and travellers are more likely to experience chest pain, arthritis and respiratory problems, twice as likely to experience depression. Significantly more likely to have a long-term illness, health problem or a disability, and 3 times as likely to experience anxiety. So that gives you a little bit of an overview. So there's a lot of early onset frailty. And we haven't really got the cancer statistics for the community, but if you look at the general statistics, you know that they're going to be a lot, you know, very similar in that respect. And I'm going to pass on to Mihai now, can talk a little bit about Roma health. Thanks.
Yeah, sure. So again, just sort of repeating on what Michelle mentioned, the fact that the data is not there, the fact that our communities are all kind of grouped under the same abbreviation makes it very difficult to have a very clear understanding of aspects of our distinct communities. The data mentioned here on this slide is actually from what we know at European level. As Michelle mentioned, there is a considerably lower life expectancy for the Roma communities. At European level, 15% of European Roma suffer from a disability or chronic disease, and the breakdown data in different countries is even sort of more significant than the European level. Child mortality rates for Roma are between 2 to 6 times higher than for the rest of European Roma population. This is just a little bit of the data that we could pull out to give an example of the extent of health inequalities Roma people face. Move on to the next slide, please. Yeah. Thanks. In regards to barriers, again, this is a sort of a collection of an analysis that we've done throughout our work both at FFT and Roma Support Group through the Health and Wellbeing Alliance program over the past few years, where we've seen huge problems that our communities face in regards to registering and accessing primary care services, mainly to the different requirements that our communities are subject to in regards to the process of registration. There is some research that we've undergone, which is soon to be released, which will give us an extent of these problems, including the extent of access to primary care services, including online primary care services and so on. We're already seeing, for example, that 12% of overall all GRT communities were not registered with a GP, and 11% of them told us that they actually are not using primary care services at all. Again, we're mentioning the NHS data dictionary here as a barrier because it is something which is preventing us from understanding the barriers that each of our distinct communities have in regards to accessing NHS services. For the Roma community specifically, unfamiliarity with the UK health system is another aspect which is preventing us to access services. And if we can move on to the next slide, please. The lack of cultural competency is another one, significant one, which influences the experiences that our people have while accessing the NHS services. And this is also seen in the way the services are being designed. Which includes a lack of awareness on the things like low literacy, language barriers, especially that Roma people face, and levels of digital exclusion. Lack of appropriate communication methods is also problematic, where we're seeing the system put in place by NHS services in regards to how they communicate with patients are not always accessible to those from our communities. And this includes a lack of suitable interpreters. It includes the way letters are being sent or drafted and so on. And also there are issues around trust and fear of discrimination, which is an element sort of distinct for our communities because of the sort of past experience and unfortunately also current experiences that we have in regards to the way the system has and is treating our communities. For Roma, this is more sort of even more sort of acute, given the way that we've been treated in Central and Eastern European countries, especially in the past century, I would say. We can move on to the next slide.
Mihai, just to give you a 1-minute warning, if you could finish in 1 minute, please. Thank you.
Thanks. Next slide. Yeah, I'll continue with this. So we're actually doing currently some work to understand the full extent of digital exclusion and what enables our communities to access services through digital means at the moment. And the data will be soon published in a report. But we're seeing that quite a lot of people from the GRT communities have access to a device such as a smartphone. But at the same time, we're seeing that, for example, only 48% of GRT people have access to mobile data, and only 38% have access to their own Wi-Fi. And that's give us some extent to this issue. Again, there is very little data available on this, and hopefully what we will publish will help a little bit with that. But what contributes to this is also issues around literacy and language barriers, which I've mentioned, with our communities experiencing quite higher levels of illiteracy or functional illiteracy as well. And there is very low English proficiency within those from the Roma communities especially. Confidence in regards to using technology has also been mentioned by other groups here as well, and it's of course a significant issue for Roma as well. Again, that trust with services coming from, especially from the experience of discrimination we've experienced in the past, and especially for nomadic communities, the connection with issues and access to reliable electricity is a significant issue. Next slide, please. Yep.
We might just have to go really quickly, perhaps to the final slide, Mihai. I'm sorry, just because in the interest of time.
So I think all of these recommendations we're mentioning have been mentioned by others today. A very important one is avoiding the digital by default. Many people have told us that they would like to learn how to improve their skills on accessing digital services, but at the same time, quite a few told us that they will actually need to continue having the in-person access to services. You will have access to this slide, so you can kind of look into this into more detail. I mean, we've included also some sort of examples of what is already out there in terms of a good practice. So hopefully that will help.
Brilliant.
Thanks
Thank you.
much.
Thank you both. And sorry your time's so short, but hopefully as an audience, it's given you a bit of a flavour of the kind of expertise we've got amongst some of these amazing partners that we're bringing to you today. So there is the opportunity to get in touch afterwards and read their slides. Fantastic. So last but not least, before we launch into questions, I am pleased to introduce you to Lois from the British Red Cross, who will run us through some of her slides and introduce herself.
Thanks so much, Katie. I'll try and whiz through these so we have enough time for questions at the end. Hi, everyone. So nice to be here. I'm really pleased to present our findings from our recently released piece of research on the impact of digital exclusion on access to and experience of healthcare for people seeking asylum in England. The project was called Offline and Isolated, and we published it in April. Next slide, please, Katie. I'll whiz through the method just because that's not the focus of this presentation anyway. So we commissioned a partner to work on this research with us, the Democratic Society, and together we recruited 5 peer researchers with lived experience of seeking asylum to join the project team. And together we co-produced various aspects of the research with the peer researchers, including the research tools. The peer researchers were trained in qualitative research skills and undertook 30 interviews, so 6 each, with people currently in the process of seeking asylum. They also supported us to analyse the findings and worked with us with many other organisations to develop the policy recommendations. So that included external organisations such as Good Things, the Department of Health and Social Care and the Home Office, and lots of our internal staff too. Next slide, please, Katie. So why people seeking asylum? I wanted to briefly touch on that before I go on. So refugees and people seeking asylum often experience poorer health outcome than the general population. They face a whole host of unique barriers to accessing healthcare, which includes sometimes being wrongly denied healthcare or charged for healthcare despite being entitled to free primary and secondary care, which is often due to limited knowledge of their entitlements by some staff. They're far more likely to experience language barriers and problems with interpreters. They often lack knowledge about how the health system works and how to access care, and they're at risk of digital exclusion, which was the focus of this report. Next slide, please, Katie. The British Red Cross are the largest independent provider of services to refugees, people seeking asylum and victims of trafficking in the UK, which means that we have a whole wealth of operational insight which can help us as a policy, research and advocacy team to identify where we better need to understand an issue and advocate for change. So our operational services shared with us that digital exclusion was posing a real barrier to healthcare access for people seeking asylum. And we'd heard similar things from colleagues at organisations like Refugee Council and Doctors of the World. But there was actually very little research on the topic, so we knew we needed to understand it better. And what we found was, as we expected from our operational insight, that people seeking asylum were indeed at high risk of being digitally excluded. And this was for a bunch of reasons, including not actually having access to the internet in the first place. So not having access to the internet in their accommodations, especially in dispersal accommodation, where there's not a contractual obligation for providers of subcontracted home office providers to provide the internet at all. And also just not being able to afford it. Almost all the participants couldn't afford data or broadband on device or money for devices on their very small asylum support allowance. And even if they did have access to the internet and access to a device, which many people didn't, there was lots of obstacles which prevented meaningful access. So that included lack of access to a private space, which was particularly problematic for those trying to access things like a GP, speak to their lawyer, speak to a therapist. You can't do that in a room full of other people. Lack of access to lack of digital skills themselves, or access to digital literacy training, which has been mentioned by a few other presenters before me. And language barriers, of course. So most websites and web pages that people seeking asylum wanted to access were not offered in multiple languages, so they weren't able to use them. And also worth mentioning, a feeling of general distrust of the internet, which often stemmed from concerns about how their data was going to be used, and fears relating to hospital to home office data sharing. I popped a quote in the bottom there, which really emphasises that, from one of our participants, who said, "With limited funds, it has not always been easy to go online. Communal living environment makes it difficult to have that private space to go online." Next slide, please, Katie. So in essence, how did digital exclusion and healthcare access intersect? We found that digital exclusion can both create and exacerbate barriers to healthcare access, which prevents some people seeking asylum from booking appointments, ordering prescriptions, or navigating their way to their appointments. And as I mentioned before, affordability was a real barrier, and participants just frequently didn't have enough mobile credit to wait in that often long call queue to book a GP appointment in the morning, one we're all familiar with. I think I waited 40 minutes the last time I needed to do that. So people were frightened about making those calls in case they wasted their phone credit, felt conscious of their phone credit going down. They didn't have enough data to access the NHS app, or they didn't have access to a device, they couldn't buy one, which left people to seek alternatives. So that included going straight to emergency services, which of course places additional pressure on our emergency services, which are already very stretched, or delaying seeking care altogether, which is of course a very concerning finding. Some participants found that online health platforms like the NHS app were inaccessible to them. So many considered the registration process as too complicated, with too many questions asked. Multiple step verification processes made it impossible for some who only had access to one device. Or many people found that their identification was not an accepted form. It's worth mentioning that our report found that the ARC, or application registration card, was not an accepted form of ID for the NHS app, and that is often the only form of identification that people seeking asylum have. However, we're really pleased to share that that's been changed now as a result of the finding, which is a brilliant win. Without access to the internet, people just couldn't navigate their new environments. They couldn't find out what services were around them or manage their asylum claims. And so many people, participants shared that digital exclusion led to social isolation and exacerbated mental ill health. Participants shared that digital access was just essential for good well-being, and being able to connect to family and friends, often after leaving their home countries in very difficult circumstances, was just so important for their well-being. And the access to the internet in general helped to alleviate isolation and stress caused by going through the asylum system. Next slide, please, Katie. last slide. So what have we been doing since April after finding this? So we've been working with NHS England and the Department of Health and Social Care. We're really pleased that our report's findings were integrated into the framework that Bola shared at the start, which is just fantastic, and it's such a brilliant resource. And we're really looking forward to see how it's used going forward. As I mentioned, the NHS app now accepts the ARC for registration. And we're working with NHS England to find opportunities for people seeking asylum to collaborate with those who are doing the service design, designing digital platforms to ensure their accessibility, ensure that they meet their needs. We're slowly making headway with Home Office influencing, so we're working hard to change the methodology used to determine asylum support rates to ensure that it accurately reflects the cost of purchasing data in a device. And also that the internet is written in as a contractual requirement of all providers of accommodation for people seeking asylum. And we've had some good headway with those things recently, so watch this space. Finally, worth mentioning that we're working with the Home Office to understand the potential impact of Clause 15 and Section 2 of the new Illegal Migration Act on digital exclusion for people seeking asylum. So Clause 15 confers the power to search for, seize and retain mobile phones and other digital devices. And we're really concerned that that will exacerbate digital exclusion for people seeking asylum. So we're working with the Home Office in an ongoing way to work out how we can mitigate any unintended consequences of that piece of legislation. Katie, I've just about done that in 9 minutes. I won't rabbit on because I'm sure you want to use the last 10 minutes for questions, but so glad to be here, everyone. Thanks so much for listening and looking forward to taking any questions.
Thanks, Lois. Brilliant. Thanks for pulling us back on time. Brilliant. Just wanted to quickly summarise the takeaways, but I'm just going to put them on the screen and not talk about them. So while we do that, last few things to do. So we will take maybe one, maybe two questions. We might be struggling to do any more than that. I will put contact details on the screen for those individuals that have presented today. So if your question is asked, you've got a mechanism to follow up. And then finally, we just need to do our end of session polls. So Q&A. So Jo, Meg, one or two questions that we could put to the panel, please.
Well, thanks to Emma Stone's been beavering away in the chat, answering some of people's questions as they come up anyway. But there are a couple of things that I think we've got time to explore. So there are a couple of comments and questions around the same theme about, I think the question is, how hopeful are we that increased digitalisation of healthcare services done in the right way might free up healthcare staff to actually provide more face-to-face support to those people who remain digitally excluded and cannot or choose not to engage with digital health services. Is there any evidence of that happening? How hopeful are we that that could be the future? I might pose that to Emma Stone first, and then the others can jump in after that.
Yeah, thanks, Jo. So realistically, I am not hopeful about that in the short term because of the extent to which NHS and other public services and voluntary sector services are under such pressure at the moment. And also the reality is that supporting people to be able to learn and benefit from digital also takes some investment of time. And I think one of the things that we and others have identified is that actually, whilst we've focused a lot here on people who are using services who may be from different inclusion health groups, there are big issues about the digital confidence and skills and understanding of people who are within the workforce of health and social care. So I think in the long term, that is something that may happen. In the short term, I don't think that would happen, but I would also challenge that as a very narrow framework, because part of the big picture issue here is that access to digital inclusion is also about the whole of people's lives. It's not only about healthcare access. It's not only about efficiencies, for example, within a GP practice. So it's a tricky one. That doesn't sound particularly optimistic on that direct question, but I think the optimism comes from that wider view of the extent to which investing in this supports people's lives and life opportunities across the board. And that is where ultimately you will see reduced pressures on primary care and on secondary care.
Great, thank you, Emma. Do any of the other speakers want to come in on that, perhaps in relation to your specific communities that you support?
Shall I jump in?
Yeah,
So that's a big question and a big wish. I think what improves is the choice and control. So we heard from people how the fact that they were able to see a GP if they could see them visually, the GP from the comfort of their own home, if they might be more anxious about going to a GP's practice, would could be a really positive thing for some people. The flip side is actually getting used to going somewhere can help, and having the good support there. So I don't know if it's going to save things, but I think the wider offer, the more options there are for people to engage, the more likely they will be able to find one that works for them. And I think that's more the point of it.
Great, thank you, Madeline. And a final quick question is, to what extent do we think that health literacy more generally as sort of a bigger concept is intersecting with people's ability to engage with digital services online? I might pose that question to Lois, perhaps. Is the concept of digital literacy something you've explored with asylum seeker and refugee communities? Does it intersect with digital exclusion?
Oh yeah, happy to jump in. It's a little bit of a tricky term, and places, I think, sometimes undue emphasis on people's own kind of agency in acquiring digital skills. However, yes, of course, so people seeking asylum have arrived in the UK and are not familiar often with how our health system works, and the health system that they come from is often wildly different to ours. So that has a whole host of problems. It can cause people to have expectations about what the health system should look like when it doesn't, and does serve as a barrier to accessing care. So, of course, if people haven't accessed healthcare digitally before in their home countries or countries that they've lived in before arriving in the UK, that can cause additional pressures. Can place an additional barrier when they're trying to access healthcare digitally when they arrive here. Hope that's helpful, and I'm happy to chat to whoever posed that question if they're interested in our community in particular.
Brilliant.
Thank you, Lois,
so much. So, Jo, do you want to pop the poll up on the screen?
I will do. Yes, please. So this is just a repeat poll of the second and third question that we asked you at the beginning of the session, just to see if there's any change in your knowledge or confidence having listened to our wonderful speakers today. So I'll leave that poll up. Please remember to scroll down to the second question. Leave that there for a couple of seconds.
While you're finishing that off, which as some of you will be, I can see the numbers going up, just to leave on the screen a bit more information about our offer as Good Things Foundation, and to say there are 2 more seminars. Tomorrow we'll be exploring more the barriers that affect people, which you've heard many about today, but we'll draw together some more of the themes that we hear consistently across all of the audiences that we represent. And then Friday is much more focused on top tips, solutions, how you design. So hopefully we'll get to see you there. And if you aren't able to join us, please do look out for the recordings, because they will be available within the next week or so for you to access. Thank you to all our amazing speakers today. Thank you for mostly keeping to time. You did a really great job of kind of just highlighting the needs of your populations and the work you've been doing. And thank you all for attending, and hopefully we'll see some of you tomorrow.